I want to thank everyone for teaching me everything about T cells and CAR cells in the past day. But one thing that I do want to remind ourselves is the devil is the teacher, has been all these years. And what is the devil? That's the disease called neuroblastoma. And just not to lose sight that we take care of patients who come to us with metastatic disease. And what is shown here is the child that came to us with stage 4 neuroblastoma. And metastatic disease, is 90% of the mortality in general for cancer. So I think this is a big issue, obviously. And this neuroblastoma actually spread, as you can see, in the bone marrow, in the bone. And this is the age group where these are older kids, and they come to us with massive disease and widely metastatic disease. And you sort of look at them and say, wow, this is going to be tough. I would say in my fellowship days, none of these kids have survived. And so this has been a big problem over these years. But luckily, I can report to you that not because of me, but because of a lot of effort in the field, neuroblastoma is absolutely survivable, and at least 50% of the kids will survive. Now, on the other hand, this group, which is the good risk patients, which we're not going to talk about, but there's such an amazing biology that may help us understand some of the immune phenomenon as we go on. But as we looked at antibodies, and I have to say, when I started out, I was just very naive. I made a lot of antibodies using hybridoma technique. In fact, I was learning from Dr. Juan Levy's lab. So my freezer has truckloads of antibody. And as we go down the priority list of all the antibodies, one of them that struck me, because they keep coming back, was ganglioside GD2. We have made 17 different antibodies against this ganglioside, but they keep coming back as we immunize the mice. And so we start using ganglioside antibodies. And one thing that, as you notice on this cartoon, is that all the antibodies we've been using over the last maybe 2 decades, until more recently, has been primarily taking advantage of the FC portion of the molecule. So if an IgG antibody like a 1418 or 3F8 antibody, if you have a FC receptor, like on the monocytes or on the neutrophils or on the NK cells, then you have a chance of killing the tumor. Obviously, FC is a big part of how these antibodies work. And it leads us to think about, for example, FC receptor affinity, FC receptor homomorphism, ways to enhance the FC functions. Of all these phenomena, actually, as we look at them, begin to teach us that there are some mechanisms where these cells are inhibited. For example, as Paul just explained in some detail, the KIR is actually a family of molecules that actually inhibit NK cells, and these turn out to be actually quite important. Now, the other half of the cartoon is really the last might be 5 or 10 years. When we start asking questions, how come we are not using those T cells? Why not use T cells too, using a mechanism, as we have talked about in the past couple of days with CAR, for example? I'm going to focus on bispecifics, and there are reasons why I want to focus on bispecific antibodies, because it's an off-the-shelf approach. You don't have to tailor-make individual drug for each patient. And also, I'm just not good at making CAR. So as we now look forward and try to understand how far we've come or how little we have done, GD2 is a great system because GD2 ganglioside, for those of you who may not know, this is a carbohydrate on the lipid. And actually, as you look at the synthetic pathway, every single epitope neighborhood is known. So when you're trying to make an antibody, you know exactly where your cross-reactivity is going to be. And this is actually very important. As we try to engineer antibodies, make it more high affinity, or make it whatever, you need to know what your neighborhood is so that you don't cross-react with all your neighbors. And that's what Entropia did. When we affinity mature these antibodies, we want to make sure it's not going to react with GD1B, for example, which is on sensory neurons, or GD1A, which is on motor neurons. And this is actually quite important. Knowing the epitope neighborhood allow us actually to go in very, very, very precisely what to modify. GD2 is also present on many different tumors. Besides neuroblastoma, as listed in here, like some of the osteosarcoma, rhabdomyosarcoma, Ewing sarcoma, as well as some of the adult cancers. Now, this sort of summarizes what we've done in the past 30 so years. We took the antibody 3 as a mouse antibody and actually start using it in a number of settings. And I'm just going to show you one analysis looking at patients who are treated in first remission. So what you can see here is that as we follow these patients over the last 20-some years, the first regimen we used back in the late 80s was a regimen where we use antibody instead of bone marrow transplant. And the whole concept then was to see if there's a way we can replace autologous transplant, at least in those days when the transplant was quite toxic, and we were losing patients because of the high-dose regimen. We thought that this may be of interest. And in fact, it turns out that this group, which is patients with high-risk disease, stage 4, patients with metastatic disease of bone marrow, more than 18 months of age diagnosis or MYC amplified, we have a 40% overall survival. And this is actually maintained survival over those last 20 years. And these kids are now finishing their PhDs and law schools. And this is obviously important as a long-term follow-up, because one of the things that we do not know is what are the late effects of treatment from anti-GD2 therapy, and I can report to you there's none. We have not seen any late effects directly related to the anti-GD2 therapy. You know, as we move on with the different regimens, we combine them with GM-CSF from regimen B, and also from IV GM to sub-Q GM. Now, this is the area where we bring back transplant, and this is really because of the study that was from Cox showing that there was a benefit from autologous transplant. So in these cohorts, we have some patients that were transplanted and some that were not transplanted. There's a group which is called ultra-high risk group. These are the group that did not go into remission with the induction regimen. And so it's actually encouraging that these patients were doing actually pretty well. And I think that really of interest was, now that we have that study and we're looking backwards and we ask the question, what are the prognostic factors that determine outcome, survival? What are the factors that influence outcome? And obviously we looked at the impact of not going into remission, which is obviously a high risk factor with the induction regimen. We also look at transplant, whether it did in fact make any difference. And in this analysis at least, we didn't see any impact of transplant on the outcome of these patients. But one thing that was of our interest was we actually saw that there was an influence of GM-CSF on the outcome in this multivariable analysis. Again, supporting our in vitro data and all the data that Paul had mentioned, that the granulocytes or the myeloid cells have a role to play, whether it was directly anti-tumor ADCC, or whether this is maybe a myeloid-mediated anti-tumor effect through other mechanisms we do not know yet. But the KIR, again, came back as borderline significance. Now, this is when we were looking at a simple way to look at KIR, either missing all ligands or some ligands present. But now we've actually done a more detailed analysis, and Dr. Kathy Su has actually done a very detailed analysis looking at 3DL1, for example. When you look at 3DL1, this is one of those KIR inhibitory receptors. You can actually see strong interacting, weakly interacting, and no interacting pairs, and they stratified actually nicely in terms of outcome, which I think is really, again, pointing to the fact that the KIR plays a role in probably the ADCC phenomenon, which is, again, suggesting the unlicensed NK cells play a big role in the anti-tumor effect with antibodies. One thing you also want to mention, though, that we have actually been measuring MRD, which is really an interesting concept, that when we look at MRD measurements at the end of therapy, and this is shown in here, at the end of all therapy, when we look at MRD using a 4-marker panel, these are essentially quantitative RT-PCR assays, we actually saw no difference in terms of predictive power as to the patient's outcome. But if you measure the MRD again, after 2 rounds of immunotherapy, you actually separate out the patients, those who are going to live and who's going to die. And again, this tells us that the immunotherapy, which is what we're using in here, has an impact on this disease status, which is absolutely predictive. And this has been confirmed in multiple other studies we've done, both in secondary remission patients, primary refractory group patients. And it's something that I think we can potentially use as a way to guide therapy or personalized therapy. But the lesson that this study taught us, again, is actually manifold. One of the things that we noticed was that after this antibody treatment, patients don't generally relapse in the bone marrow anymore. Not that none, but they usually relapse in other sites. There are those obviously relapse with extensive disease, what we call multiple sites, bone marrow, bone, soft tissue, and everything. But what we are seeing is that there are some sites that we never even thought about. And the one site that is really struck us was the brain. For neuroblastoma, brain metastasis is not described in textbooks if you look at diagnosis. But we're beginning to see brain metastasis as we started the immunotherapy program, and that started about 15 years ago. A story which is almost reminiscent of HER2 positive breast cancer and relapsing with brain mets after Herceptin therapy. And this is of interest because obviously antibodies cannot get into the CNS, but why is it that we don't see that in the past? Well, it's possible that these kinds of tumor may be compartmental. There are some clones that are sitting in the brain, there are clones sitting in the bone marrow, there are clones sitting in soft tissues that you need to deal with somehow. And what we think is going on is that the antibody, when it's given intravenously, is taking care of the bone marrow compartment, but not so well in taking care of the CNS compartment or even soft tissue compartment. And what we saw actually was that, first of all, as Paul was mentioning, we seldom see responses in soft tissue, whether they are big or small, which is striking. Soft tissue don't seem to respond to these antibodies. Obviously, I think the microenvironment probably play a role, but it's not so much related to size. They just don't respond. The second thing is that what we see most of the time in relapses is isolated. Now, when it's isolated, I mean that they either relapse in one single site or at least maybe two. And because of that, these patients actually are very salvageable. In fact, 25% of these patients are actually alive and well today after they relapse and going back onto chemo and then more immunotherapy. So as we look at this, we don't think that relapse patients are not incurable. We think that they're actually very curable. You just have to put them on the right regimen. I think Rupert has sort of touched onto that also, that there are ways you can actually use this therapy even after the patient's relapse. Now, when you look back at the reason why we give it IV and antibodies and somehow they only work on the bone marrow compartment. If you look at NK cells in the human, not in mice, in the human, what is interesting is that the cell that is what we want are the one that are CD16 positive cells, which is the one they're doing ADCC, actually circulate in the bone marrow. They don't really go to tissues. In fact, they're missing in most of the cancers that people have looked at. So it now comes back to the question of NK cell trafficking. Where are they, and are we have enough of them in tumors to do the job that we want? So it brings us to another question then, besides the inhibitory receptors we have to deal with, there's a trafficking issue we need to deal with if we're going to move ahead. But the biggest issue, as I had mentioned, was the brain mets, because this is catastrophic. When a patient had all this induction therapy, went through all everything, are in perfect remission, absolutely perfect remission, and come back with isolated brain mets. And we are seeing this very actually quite not uncommon. We actually have looked at 80 patients now at Sloan Kettering with brain mets after neuroblastoma. So not an epidemic, but it's not isolated incidences. So what exactly are these brain mets? Well, they're in the parenchyma. They're not dural-based. They're not extending from the bone. They're inside the parenchyma. So the way we do this is, in the past, it's been surgical resection, radiation, some chemotherapy. Unfortunately, that approach has never cured a single patient that we have. And in fact, there are patients that come in here with multiple lesions, and this is even more difficult. I can tell you both these patients are alive and well today. So what exactly could we do then? Well, as I go through my freezer that day, and I ask the question, what is the next antibody we can use? And there's an antibody called 8H9. And we picked that antibody for a number of reasons, because it actually reacts very well with most of the solid tumors and not much with normal blood or tissues. And it turns out this is an antibody actually binds to the B7-H3 molecule. B7-H3 is one of these probably inhibitory ligands for yet, as Crystal mentioned, unknown receptor. Everybody's trying to find that receptor, and I think someone is going to tell us. But despite the fact that we don't have that pathway all worked out, it actually has the potential as a checkpoint blockade, like some of the discoveries people have with PD-L1, for example. So this antibody, 8H9, has now been humanized. But I want to mention, we actually now know precisely what the epitope is, because from the crystal structures we have done, both on the antibody as well as on the homology models we built, we showed exactly this is the FG loop on the B7-H3 that the antibody is binding to. Now, the FG loop for the B7-H3 is critical for the biological function of the molecule. It actually is there's something about folding of this molecule that it is required, at least based on all the crystal structures on the mouse protein. In the human, it's actually very homologous, and that's why we were able to actually predict the epitope based on basically docking experiments, and then we went ahead and make fusion proteins to prove, in fact, that is the epitope. So with that antibody, again, it was the early days, 15 so years ago, we were using the mouse antibody. We designed a regimen for these patients who come in with brain mets. And we know that these patients, even though you resect the tumor, they will relapse either in the site, the disease, or relapse in the leptomeninges, or they relapse systemically. So it's a third and third and a third. So what we like to do at that time was to actually just give the antibody through the CSF to prevent leptomeningeal spread. And this is why these regimens were designed. So these patients that get resected, it's hard to be a total growth resection, as you can see from these brain mets, but we try. And then we'll give some low-dose radiation and some low-dose chemotherapy. And that's what we then use is the intraocular used through the CSF for radioactive either 3F8 or 8H9. And the patients actually continue on the immunotherapy to maintain the systemic remission and a few other things, obviously. This is a phase 1 study because we had no better treatment at that point because our historical data was pathetic. Everybody died. So we were actually very happy to see that with this combination regimen we designed, and Dr. Kramer has been the one who has been running the study, and the survival is actually maintained. Now, we have an update of this now past the 12-year point, and it's about 60% of patients are alive and well in remission, no brain remission, no relapse, no systemic relapse. And I think this tells us another lesson. Compartment is extremely important. There are certain compartments in the body which is out of reach. That's why I was so curious when Stephen had mentioned about this, CAR cells going in the CSF, because this is so important that if you can protect that CNS compartment, I think this will take care of some of these issues that we have. Now, obviously, the 8H9, the fact that it's a B7-H3 molecule is a tremendous target that we can go after because it is present on all solid tumors, pretty much, not on lymphoid cells, not on peripheral blood. So we're actually using it as a tumor target, and we go after another disease called a Desmoplastic round cell tumor. Dr. Shaquille Modak, who's here, has been running the trial. Again, what he showed was that these antibodies, when radiolabeled, actually stays in the peritoneum and deliver the radiation that we want as an adjuvant for patients who are post-surgical resection. And this study is still ongoing. But the one that is actually still, to me, was just so striking was Dr. Sweden, who's a neurosurgeon with Kim Kramer, basically now starting to look at this intrapontine injection. As you know, diffuse pontine glioma, it's an incurable disease. I was told that no or very few patients live beyond 2 years. So the idea is that if you can take this antibody, which reacts with diffuse pontine glioma, in fact, with any metastatic brain tumor, and if you can tag with a radioisotope and inject it directly into the pons, which is shown here. This is a patient who has this antibody labeled with 124, which is a positron emitter. You can actually see that this antibody, once it's injected, stays within the tumor over 8 days. And in fact, it doesn't even go away. So the dose that is delivered to the tumor was very high. Also remember, 124 is a positron, so it annihilates the electrons. It's an antimatter, annihilating matter. So in that process, it actually destroyed the tumor. So this is why this is of interest. It's a theranostic approach, both dosimetry and therapeutic. And Dr. Kramer mentioned to me that she was really happy because there are kids now living beyond 2 years and doing well. So I think that this is obviously another approach where, again, compartmental, you're doing it right into the tumor. Now, whether we can combine that with what Dr. Paul Sandel was saying with IL-2 and maybe to enhance that anti-tumor effect, I think it would be of interest. Again, the idea of abscopal effect, whether you can combine radiation with some of these checkpoint or IL-2 strategies. But those are what I call the first generation antibodies. We've now gone beyond that now. So we've humanized everything under the sun, we've humanized. And we need to go beyond the second generation, and that is what I call the third generation antibody. And really it is that hearing the talk from yesterday, I think we are pretty much convinced that there's a great potential for T cells. And I'm certainly one of those who are now finally convinced that there is absolutely a role for T cells. And how do we take advantage of it? And one way is to make bispecific antibodies. Of course, there's another, which is CAR T cells. We also look at the way to improve radioisotope targeting. And the reason why that is, although I didn't mention it, we actually run a number of those studies which has not been even reported yet, where we actually add in radiolabeled antibody into our upfront regimen. We did not see any improvement in survival. So what it tells us is the way we were doing radiolabeled targeting using iodine-131, using a 20 millicuries per kilo dose is not enough, or at least it was causing so much myelosuppression, we just could not move forward. So that's why we need to say, well, can we design a better way to deliver drugs or deliver isotopes? So we start off with the humanized. So the humanized Antibody-308, for example, we actually now almost complete phase 1 study. We actually do have one that is single agent by itself in combination with GM-CSF, in combination with IL-2. And we have a study where we're looking at imaging with the Antibody-308. And these are our core group that are actually running all the clinical trials. There are a couple of lessons that we've learned already, but I just want to summarize quickly on the PK. The PK is actually so important now in my mind that we really need to appreciate exactly what it is doing. And for antibody anti-GD2, for this humanized 308, one thing we learned was that, first of all, the AUC is very linearly proportional to the max, Cmax. So you can draw a single blood at the end of infusion, you can predict what the AUC is going to be. So it really now helps us designing almost like personalizing every individual patient, what drug exposure they're going to get. Why is it important? Well, because when we look at the AUC, it does look like that those patients who get a certain cumulative level of AUC are the ones who are surviving the longest. So AUC now is correlated with outcome, and that's why it is actually very important. But the thing that was surprising to us was actually this relationship of AUC or Cmax with body weight. These patients all get the same dosage. They're all per meter square, per kilo dosage. But it turns out that the little kids are much more underdosed than we thought. They actually has much lower exposure based on area under the curve. And maybe that's why when we look back at our patients who are getting GD2 therapy, the little kids sail through the treatment. The big kids are the ones that had real problems. And I think that what it tells us is, should we now look back at this AUC and think about how we dose our patients instead of just using a straight single-digit number, milligram per kilo. And there are a few things that we also learned, and one of the things that it was encouraging that the human IgA was non-immunogenic, at least non-immunogenic compared to other antibodies. So we're now moving forward then, what do we do with the human IgA? Well, there are many things you can do with it now that we know the importance of these antibodies in terms of affinity, both in terms of the antigen and the affinity for the Fc receptor. And that's what we did. We actually affinity mature based on crystal structures and computer modeling our antibody. For example, this is a binding curve on the vehicle, K on, K off, and this is chimeric 1418 or humanized 1418. And 3 of 8 is here, has a slower K off, but we can actually improve it further by actually affinity maturing it to a very slow K off. So here we have a whole series of antibodies with differential affinities. And that hopefully will help us understand some of the biology. But also, as we move forward into the clinic, this is our animal study where we actually take mice that are planted with human tumors and inject them with an antibody parental versus the affinity mature, which is in the orange. And there's a much better anti-tumor response when you have high affinity antibodies. We also did the following, and that is we affinity mature the Fc part so that we bind better to the Fc receptor. Now, the way we do it, we use a special glycosylation method, which is essentially a choke cell that is deleted of this enzyme. And when the enzyme is deleted, these antibodies come out without fucose, but gain mannose. And the reason why that is important is because these antibodies now bind much better to CD16, but not to CD32B. So the activation inhibitory receptor ratio is very improved. And it was actually true that when you compare the anti-tumor effect, it was actually much better than most of the other affinity mature antibodies. And again, shown here, when you look at the black line, it has a much better anti-tumor effect just by changing the Fc. But the real, I think that the change we can approve is really looking at the T cells, because if you can engage the T cells, we now are bringing in a whole different population of effectors that we never used before. And this is where we first designed our the bispecific antibody. Now, this is a construct which is very much like what Paul was just saying, attaching your extra molecule to the light chain part of the IgG. We like the IgG framework because this has a much better PK than the blinatumomab, which is very fast clearance, and it comes out of the blood very fast. By poking in an anti-CD3 antibody, a single chain, now you can directly activate the CD3. And what happened now is these killing of the tumor is very strong, as shown in this killing curve. If you look at this killing curve, EC50 is 0.00 some nanograms per mil. That's femtomoles. So most of the antibodies we talked about in ADCC is in picomoles or nanomoles. This is in femtomole. And this is ET ratio of 10 to 1. When you look at normal cells, like adrenal cells, lung cells, cardiac cells, that's a wide margin of safety of 100,000. So we think that this is at least, based on a test tube experiment, it should be safe. Now, however, though, if you think the neurons, neuronal cells is GD2, so neuronal cells are going to be killed very effectively. So there's always this concern that BiTE or bispecific antibody potentially could cause neural damage. I'm glad, though, that the CAR story has been saying that there's not much neurotoxicity with all the GD2 CARs, but I think we have to be really careful, again, if you're going to take this to the clinic. It is good, though, that the killing with the EC50 here is directly proportional to antigen expression, and there's no inherent resistance in tumor cell lines, whether you look at lung cell lines, osteosarcoma cell lines, neuroblastoma cell lines. And it goes by the classic T cell killing mechanism as shown in here. Actually, when you have the bispecific antibody, you form classic immunosynapse, where like when you activate T cells with KT3 compared to control antibodies where there's no real synapse formation. And also calcium flux and so on. But one of the things that's really important, though, is that these bispecific antibodies, in the presence of T cells, when there's no tumor, there's no cytokine release, unlike OKT3 or the anti-CD3 antibodies. But when you put in tumor cells, they start releasing cytokines. And this is true for gamma interferon, TNF-alpha, IL-2, IL-10, and also IL-6. So at least it says that it is not a spontaneously releasing cytokine drug, but it potentially still could cause cytokine release syndromes if the patient has tumor. So what we did was we now show us what does it do in a mouse model. So there are several mouse models we looked at, and I want to focus only on this one because this worked very well. No surprising. You give your tumor cells in the same compartment. You give the antibody IV. You kill the tumor. When you have the tumor in the IV compartment, IV cells, you will kill the tumor. Now, I think I'm running out of time, but what we showed, though, was if you look at this, striking, though, you have this dramatic effect of the bispecific antibody, and you can see that when there's control antibody, there's no infiltration of T cells. When you have the bispecific antibody, you have infiltration of CD3, CD4, CD8, and also monocytes. And one thing that is really interesting is that these tumor were going away despite the fact that you have PD-1 expression in the T cells, as well as PD-L1 induction in the tumor. So at least these bispecific antibodies to us looks like it's not seems sensitive as much to the PD-1 and PD-L1. Why do we not go with CAR cells? Well, this is the reason. When we look at CAR T cells using 3 of 8 compared to bispecific, we have this striking dichotomy that CAR T cells, at least with the 3 of 8, were dying in front of us. Although they killed the tumor, they could not proliferate, in contrast to the bispecific. And therefore, we actually chose to develop the bispecific from then on. I'm going to basically skip because I think I'm completely out of time, right? To basically say that of all the things that we've learned so far, one thing we need to do, though, is to see what we can do now to eliminate the inhibitory receptor. And this is why we're focusing on the C3DL1 by making humanized antibodies against that KIR so that we can actually modulate the inhibitory pathway, just like what we do with PD-1 or PD-L1. And the thing is also cytokines. I think cytokines are going to be critically important as we move forward. And obviously, none of this could be done without everybody who's involved. And I think all the investigators and people who I get cell lines from. And again, thank you very much for your attention.